Suresh sir, you can start.
Okay. Good evening, everybody. Now we start the 32nd weekly webinar, Pudukkottai Budan from ISA Pudukkottai branch. At the outset, I invite our Secretary, Dr. Periyasamy, to welcome the speakers and proceed with welcome address. Over to Dr. Periyasamy.
Thank you, sir. But Dr. Parthasari screen is appearing. Okay, thank you, sir. Thank you. Good evening to all. Respected Academic Chairman Dr. A.L. Meenakshi sir, President Dr. Suresh Kumar sir, Treasurer Dr. David, and members of ISA Pudukkottai and delegates. I welcome you all for this 32nd ISA webinar program, which is conducted by our ISA Pudukkottai for the past 6 months. Once again, I welcome you all for this program. This program is named as Pudukkottai Budan. Every week of Wednesday, we are conducting this program from 6 to 8. So we entered 32nd program of this week. So we already discussed so many topics, so many important topics related to PG exam point of view. And this week we are going to talk about 3 important topics. One is neuro monitoring in scoliosis surgery. Another one is oxygen therapy devices. Third one is oxygen toxicity. So these topics are very important. Last week we talked about anesthetic management of total knee replacement and anesthetic management of pheochromocytoma and anesthetic management of awake craniotomy. So we entered again in the 32nd program. This is achieved because of continuous effort and hard work of our academic chairman, Dr. A.L. Meenakshi sir. At this juncture, I would like to thank and welcome our academic chairman. So today for these 3 important topics, I invite Dr. Kannan, Professor and HOD, Government Theni Medical College, Theni, Tamil Nadu, as a chairperson. I welcome you, sir. And next, for the 3 topics, first one is neuro monitoring in scoliosis surgery. For that, I welcome Dr. Jacob, head of the department, KIMS Health Trivandrum. I welcome you, sir, on behalf of ISA Pudukkottai. And next topic is oxygen therapy devices. The well-known speaker, I welcome Dr. S. Parthasari, Professor, Mahatma Gandhi Medical College and Research Institute, Puducherry. I welcome you, sir. And third topic is oxygen toxicity. For that, I invite Dr. Divya Dharan, a resident, Government Theni Medical College, Theni, Tamil Nadu. I welcome you, madam. And one more important thing is this program is accredited by Tamil Nadu Medical Council for credit hours. They are giving 0.5 credit hours for the participants and 1.5 hours for the speakers. For that, we need certain details. There your attendance and your email ID and contact number. And you have to pay 100 rupees to be paid for the following account number. You can note it down: 3856859628, State Bank of India, Annavasal. Those particular has to send our email ID isapudukottai@yahoo.com. isapudukottai@yahoo.com. And today we are going to talk about topics about oxygen. So, as I am concerned, ISA Pudukkottai oxygen is our ALM Meenachundram sir. He is continuously, we are surveying because of him only. So a small poem about that. Oxygen. On the air, every living organism to breathe. Enough oxygen is everyone's right. Trees are giving us free oxygen, taking towards the lung, called as respiration. As the fire accounts for all energy. Oxygen, as the fire, accounts for all energy. As the treasure, accounts for all living source. Carbon dioxide emission cuts short oxygen emission. Oxygen existence is essential for every life commission. Oxygen existence is essential for every life commission. Flow of oxygen is the fuel for brain. Flow of oxygen is must to treat all pain. Flow of oxygen is must to treat all pain. So oxygen is the love and oxygen is our soul. With this, I thank you all. Thank you all. Thank you for the opportunity. Over to President Dr. Suresh Kumar sir. Thank you, sir.
Thank you, Dr. Periyasamy, for your enlightening welcome address. On behalf of ISA Pudukkottai branch, as President of ISA, I welcome you all for the 32nd weekly webinar. Really, it is a marathon run, 32 weeks non-stop of academical activity from ISA Pudukkottai branch. At the outset, I thank our academic chairman for this non-stop 32-week webinar conducted every Wednesday with very much useful practical topics, eminent speakers all over India, and importance to the resident giving a talk in the Pudukkottai Budan every week, which is a unique and new event which is being undertaken by our academic chairman. I welcome our chairperson, Dr. Kannan Bojaraj, and speakers, Dr. Joseph Jacob, Dr. Parthasarathi sir, and Dr. Divya, who have come here. We are very honored and blessed, and we are very eager to listen your lectures and wonderful discussions following which. I welcome every member, every anesthesiologist and members of ISA Pudukkottai and other branches who are assembled here and make use of this program every week and participate in the chat. Once again, I thank Dr. ALM sir, and I hand over the proceedings to Dr. ALM sir. Over to Dr.
Thank you. Thank you, Dr. Suresh Kumar, President ISA Pudukkottai, respected Secretary ISA Pudukkottai, and the Treasurer and other members, and a distinguished faculty. A good evening to all. Today is a special session because one faculty is from Kerala, another faculty is from Pondicherry, another faculty is from Tamil Nadu, and the chairperson is from Tamil Nadu. So the three states conglomerates under the banner ISA. So I welcome all of you. And today we have our youngest speaker, Dr. Divya, who is going to talk about oxygen toxicity, which is a very vital topic. And as an anesthesiologist, I insist whenever oxygen is given, it should be prescribed as a drug. It should not be given casually. That is the reason why we are interested to listen to Dr. Divya on oxygen toxicity, because we all should remember oxygen is a drug. Whenever it is administered, we have to prescribe the hours and the mode of delivery and the volume of the gas which is to be delivered. It should be prescribed. So to insist that she is going to talk on oxygen toxicity, and she has graduated her MBBS from Dharmaburi Medical College and doing third year residency in Government Theni Medical College, Tamil Nadu. And her extracurricular activities are she used to write Tamil poems. And to supplement that, when oxygen toxicity is informed, then we have to think of how to deliver oxygen without toxicity. So the person who is going to deliver the lecture is a person who is versatile. And if you want to introduce Dr. Parsardi, Professor, Mahatma Gandhi Medical College, Pudukkottai, it itself will be a 1 hour topic. So the majority of his qualifications are from varied subjects, ranging from acupuncture, diabetology, USG guided nerve block. So if you write his degrees, it will be lengthier than his name. And coincidentally, he is also a Tamil poet. He used to write so many Tamil poems. He has released so many poetry books. As a single man army, he has conducted Fridays, which is a continuous education program. And just because he is tired, he has taken a little break. Now we want to involve him in this Pudukkottai Budan. So we invited him, and he kind-heartedly he has accepted because he is on duty now. As it is a webinar, he has joined, and he is a great academician, enthusiastic Tamil person, interested in social service, and he is taking part in Rotary Club activities. So he is a multidimensional man, and we are happy to have him. And our Kerala faculty from Kerala, is Dr. Jacob Theophilus. See, we want to mention a special mention about him. He is a ever smiling man. See, it is very difficult to see people smiling under severe stress. But even though he has a profession, which is a stressful profession, anesthesiology, he is a ever smiling, kind hearted, soft spoken man. So he wants to maintain his academic activity continuously. And scoliosis is his pet chapter. And the vast experience of him cannot be put it in 30 minutes. So we have requested him to have 2 sessions. Now he is going to have a special thing. He is going to deliver a lecture about the priority first part, scoliosis management now. And the next week also, he is participating for the anesthetic management of scoliosis. So today he is going to talk about only electrophysiological monitoring because his expertise is so vast, and he is obliged to come for the second part also. So he is the second person who is going to get 2 successive sessions. He was his undergraduation was from Trivandrum, and he had in Kottayam. And see, he had his prestigious fellowship from Dublin, Ireland. You know that is a toughest degree, but he got it. It is a unique thing that he got his fellowship, and he is the lead consultant and the senior consultant in Kim's Health. So he is interest difficult airway management and ultrasound guided nerve block. So to manage these 3, as it is oxygen as well as scoliosis, we needed a versatile personality to chair the session. So we contacted Dr. Kannan, who is the professor and HOD of Government Teni College, Teni, and he has obliged us immediately. He has prepared our postgraduate also to present a lecture here in this webinar. Dr. Kannan is also a versatile personality. He is also a poet. So now today I thought the PG is going to write Tamil poems. The chairperson is going to write Tamil poems. And Dr. Parsardi is a poet. I used to write occasionally the Tamil poems. And to have a contrast, for so our secretary is writing English poem, Dr. Periyasamy. He is also a Tamil poet. So today is a great day. people with extracurricular activities are participating in this webinar. So it will be really a good webinar. Dr. Kannan is a yoga master. He's a direct disciple of Vedadari Maharishi, and he is a highly disciplined person to the extent, even before the enactment of law, he will never talk over cellular phone while driving. So he's a strict disciplinarian. He knows Kundalini Yoga. He has created a Sky Yoga Federation. He's a yoga teacher. So even without anesthesia, he can anesthetize people by yoga. Ever dynamic man. He's always young because of his yoga activities. So he is the president of ISA Teni, and he is heading the anesthesia department in Teni. So with this introduction, I hand over the session to Dr. Kannan to conduct the proceedings. Over to you, sir.
Thank you so much for your nice words, sir. Respected academic chairman, Dr. Elmina Sundram, sir, and the president of ISA Pudukkottai, Dr. Suresh Kumar, and secretary, Dr. Perisami. And ISA Pudukkottai is successfully conducting this 32nd edition of this weekly online program. Thank you very my heartiest congratulations, sir. It will be continued till the 100th week also. It is a very useful program for the not only for the postgraduates and also for the practicing anesthesiologists also. Today there are three speakers. First of all, I call upon Dr. Jacob CFLS, sir. So he's the head of the department of Kim's Health and Trivandrum, and he is going to talk about on this neuro monitoring in scoliosis surgery. He is so much, as per the academic chairman's words, his expertise in this neuro monitoring in scoliosis surgery, which is very needs so much of expertise. And the anesthetic management of scoliosis will be developed by the next week. I will call upon Dr. Jacob CFLS, sir, for your presentation on neuro monitoring on scoliosis. Over to you, sir. Sir, slide was
6 point ma.
Sorry.
Sir, our slides are not shared.
Yeah, just a moment. Yeah. Good evening, everybody. Thank you, Dr. Meenakshi Sundaram, for inviting me for this talk. Thank you, ISA Pudukkottai. And thank you for the introduction. I hope I'm audible, is it?
Yes, sir, it is audible, sir.
Okay, okay. Thank you. So I'll be talking about neuromonitoring in scoliosis surgery today. Now, it's just the basics for the anesthetist. What we anesthetists should know when we are tagged up with a neuromonitor physiologist. So in the first place, why do we need a neuromonitoring at all? So the number one is because there's limitations in the clinical assessment of the nervous system intraoperatively. Both our patients are asleep and we are fiddling with the nervous system. So we should have a dynamic monitor that provides us an assessment of the effects of surgery and anesthesia on the integrity and function of the nervous system. So that's why we need a neuromonitor. Now, before we go in detail about the neuromonitoring, we should be aware that we should have a monitor that is very minimally invasive, should be highly sensitive, and highly specific for the particular nervous system that we are looking for. Before we delve deeply into the neuromonitoring, we should acknowledge the people who really did investigations into this. The most important person in this is Forrester. He is a German neuroscientist.
Excuse me, sir. Go for slide share mode.
Sorry.
Slide share mode is not.
Actually, instructions are there.
Sorry, I'm not able to.
Mute all the other audience. Audience. Please mute all the
Slideshow,
audience.
sir, slideshow.
Sir, the same thing, sir. Dr. Theo. Right, sir.
Is it okay now?
Yeah. It's okay, sir.
Yeah, okay. So Forrester was the first one who did an investigation into intraoperative neuromonitoring in 1935. He was actually a German neuroscientist who did pioneering work in intraoperative neuromonitoring. He was the one who was hired by the Russians to look after Vladimir Lenin. Vladimir Lenin actually died following a stroke, and the last 2 years of his life was looked after by this man. It was later his student, Wilder Penfield, who did further investigations into intraoperative neuromonitoring and gave us a clue of how to monitor the nervous system. Now, as we all know, we have an ascending tract and a descending tract. The ascending tract relays sensory information to the brain, while the descending tract delivers motor instructions to the body. So basically, for a scoliosis surgery, the two important monitors that we monitor are the transcranial motor evoked potential and the somatosensory evoked potentials. Now, the transcranial motor evoked potentials monitor the corticospinal tracts, that is a descending tracts, while the ascending pathways are monitored by the somatosensory evoked potentials. So they assess the sensory part, and the motor part is assessed by the motor evoked potentials. Now, just a bit of detail about somatosensory evoked potentials. They mainly check the ascending spinal pathways. Simultaneous stimulation of either the median nerve or the ulnar nerve at the wrist and the common peroneal or the tibial nerve at the ankle. So those two nerves are monitored. Along with this, the quadriceps muscles are also monitored. The SSCPs are primarily conducted by the dorsal columns, and the reproducibility is recorded over the scalp. They are extremely specific for spinal cord injuries. Hypothermia significantly influences the latency of SSCPs. And when do we say that there is an alert? So basically, for a neuromonitor, there are two things that we look for. One is the amplitude and the other is the latency. Amplitude is the size of the response. You give a stimulus and you see how much response is elicited from the nervous system. That is the amplitude. Latency is the time you give a stimulus to the time you see the response. So the longer the time you need to get a response, that means the latency is prolonged. So these two things are looked for both in somatosensory evoked potentials and in motor evoked potentials. So when you say there is an alert, when there is a 50% decrease in the somatosensory evoked potential amplitude or a 10% increase in latency, that is an alert because too much distraction of the spinal cord has caused this problem. So The only downside about the SSCPs is it is a highly specific, though highly specific for the nervous system, it is less sensitive. The next one is the transcranial motor evoked potentials, which checks the integrity of the descending pathways. The scalp electrodes are used to stimulate the cortex and the underlying tissues. It gives us a rapid assessment of motor function, but is more susceptible to anesthetics than SSCPs. Alert is disappearance of the signals of motor evoked potentials. It's an all or none phenomenon. You don't look for a 50% decrease or a 10% increase in latency. Complete disappearance of a motor evoked potential tells you that there is an alert which you need to look into and solve the alert before you proceed further into the surgery. That is, the scoliosis surgery involves the use of rods and screws. So all those distractions might produce a disappearance of the signal. Then it is a time to look into it and rectify the path. The MEPs produce changes earlier than the SSCPs because SSCPs are actually a signal averaging kind of thing. So the MEPs are tells you the alert earlier than the SSCPs. When you do an MEP, you're likely to have tongue laceration, scalp burn, and also in some patients, even epileptic seizures, because depends on the voltage you deliver in for the patient. Now, this is a diagram of the spinal cord blood supply. As we all know, we have one anterior spinal artery and a paired posterior spinal artery. The anterior spinal artery supplies the anterior 2/3 of the spinal cord, while the posterior spinal artery supplies the 1/3 of the spinal cord. The anterior spinal artery is very peculiar in the sense that it's short and tortuous. So the anterior spinal artery is the one that supplies the motor tracts, and the posterior spinal artery supplies the sensory tract. So technically speaking, anterior spinal artery is the one where the motor evoked potentials are affected. And in any problem with the SSCPs, it is the problem with the posterior spinal arteries. But because the posterior spinal arteries are paired, the symptoms or the signs are seen later than the motor evoked potentials. That is why I said earlier, MEPs disappear first, and then only the SSCPs disappear. MEPs are the ones, the response that you see immediate. And because the short and tortuous anterior spinal artery, they are more likely to be compromised compared to the posterior spinal arteries. Of course, you have reinforcements from the artery of Adam-Keefe and the radicular arteries, but they play only a minimal role. And there is no collateral circulation other than that. Now, this is a picture of the wired up child for scoliosis surgery. Now, you can see there is a bite block kept in the mouth. That is because, like I said earlier, when you stimulate for the motor evoked potentials, the child is more likely to bite onto the tube or to the tongue. So always make it a point to have a bite block kept in the mouth. Of course, there is the BIS monitor is kept to detect any awareness. We have a temperature monitor, and this is the neuromonitoring to record the median nerve. So I told you that either the median nerve or the ulnar nerve is stimulated in the wrist, and then you have the posterior tibial nerve and the common peroneal nerve along with the quadriceps muscles that is also wired up for recording MEPs and SSCPs. This is the scalp electrodes that are put up. This is from the head end of the patient. This is a SSEP recording, and this is an MEP recording. So you before you start your monitoring, you always get a baseline reading, and your further readings are always compared to this baseline. So getting a good baseline before you start the surgery is very important. This is a fluid warmer that I've kept because hypothermia can significantly affect both these neuromonitors. So because it's a long duration surgery involving a lot of fluid shifts, administration of blood, a fluid warmer is definitely mandatory. This is a TCI pump, a total intravenous anesthesia pump. So there are two ways that you can anesthetize a patient for scoliosis. Either you can go totally intravenous, or you can use a general anesthetic technique involving volatiles. But the problem with using volatiles is two. One is it interferes with neuromonitoring. Number two, it interferes, it is more likely to precipitate malignant hypothermia. Children with 75% of children with scoliosis are adolescent idiopathic scoliosis, otherwise called AIS. But the remaining 25% involves multiple reasons. And of them, neuromuscular scoliosis are most likely to cause, to be associated with malignant hypothermia. So in order to avoid this phenomenon of malignant hypothermia and avoid the incidence of interference with the neuromonitoring, a total intravenous anesthesia technique is always preferred. Now, to administer total intravenous anesthesia, you need, like for a general anesthesia, you need three things. You need a drug for amnesia, you need a drug for analgesia, and of course, muscle relaxation in the beginning of surgery, because you're not supposed to give muscle relaxants once they start putting the screws, because every time they put up the screws, they always check for the neuromonitors. So if a muscle relaxant is administered, your motor evoked potentials won't be there. So also your somatosensory evoked potentials. But MEPs are more affected by the muscle relaxant. So there's no question of administering muscle relaxants after the first screw is put in. Now, to give amnesia, you have propofol that is given as in a TCA pump, because that pump specifically gives you a goal-directed dose of the drug. I'm not going into too much detail about TIVA, but this is the basic concept. Then you have an analgesic drug that is fentanyl. If you have remifentanil, that is a very good drug, because when you want to awaken the patient and do a wake-up test, remifentanil is a better drug compared to fentanyl. But since we don't have remifentanil, we continue using fentanyl. And Dexmed is added because Dexmed will produce both an amnesic effect as well as it will reduce the amount of propofol that you need to use, and also reduce the amount of opioids that you need to use. So that's how these three combinations were chosen. Now, what are the changes that can occur during a neuromonitoring procedure? So like I said earlier, the two things that we look for are the changes in the latency and changes in the amplitude. So these changes might be limited to lower extremities alone, or it can be on one side of the body, or there can be a 50% drop in amplitude or a 10% increase in the latency. Or there might be changes only in a few myotones. So these changes are recorded by the neurophysiologist, and an alert is given to the surgeon. Now, of course, you can have false positive signals as well as false negative signals. False positive signals can occur. That is, you find a total disappearance of the evoked potentials when a sudden bolus of drug is given, say we have given a bolus of propofol in order to prevent the child from moving. So that can suddenly produce a false positive signal can occur. Second is a decreased response over time. Because it's a long duration surgery, this likely to have a decreased response over time. Then there's something called a hemodynamic fade. When there's a fall in blood pressure, fall in temperature, fall in cardiac output, hypocarbia, or a fall in CVP, all these can produce a false positive signal. Now, where do you get false negatives? That is, you don't know, you still think there is no problem in your surgery, or when you put your screws or rods, you still think everything is fine. When should you be cautious about such things? One is having a poor baseline. As I said earlier, you need to have a very good baseline before you start your surgery. So getting a good baseline is the time when there is absolutely no muscle relaxants. All the intravenous drugs are in the optimal dose. After that, get a good baseline and then only start your surgery. So getting a good baseline is very important to avoid false negatives. Inadequate monitoring of myotomes is another reason that can give you false results. So these are the times when you should be aware that false signals matter. Now, a word about pediatrics. Children less than 6 years, especially when you do such surgeries for them, because of the immature neural pathways with incomplete myelination, they're very sensitive to anesthetics. So they can also give you false signals. So be aware of that. And conduction velocity is slower in children and reaches by adult age only by 6 years of age. So children less than 6 years, you should be cautious in interpreting the neuromuscular signals. Now, the effects of anesthetics on the neuromonitors. The volatiles will decrease the amplitude, increase the latency of both SSEPs and the MEPs. Even though propofol decreases the amplitude of the SSEP, it mainly depends upon the dose of the drug that you give. A very large bolus can cause a total decrease in the amplitude, but it doesn't produce as much decrease in amplitude as the volatiles. So also the latency, it only marginally increases the latency in a SSEP. For a MEP, it also produces a dose-dependent reduction in the amplitude. But if it is given in a fairly titrated dose, it doesn't affect the motor evoked potentials. On the other hand, ketamine increases the amplitude of both the SSEPs and the MEPs. So when you're using ketamine as intravenous anesthetic, your interpretation should have this in mind. Dexmedetomidine doesn't have, it has got an equivocal response with SSEPs, and it increases the amplitude in MEP. Nitrous oxide reduces the amplitude of both SSEPs and MEPs. The effect of opioids is equivocal for both SSEPs and MEPs. So when you look at this chart, what you can decipher is that the ideal combination will be an opioid plus propofol plus a dexmedetomidine. So you will get a fairly good neuro monitoring response with this combination of drugs. Now, what happens when you suddenly lose a signal? So number one is gain control of the room. That is, everything should be paused. So stop the case and announce there's an alert in the room. Number two is avoid all extraneous stimuli. There's no conversations, we are dead serious, there's something gravely wrong. So then anticipate the need for additional intraoperative or perioperative imaging if it is not available. So a C-arm can help you find whether the screws are in place or whether it has gone deeper or deviated away from where it was supposed to be. Now, as an anesthesiologist, what you need to do is Verify that there is no change in the anesthetic administration that has happened. That is, you haven't given any bolus of drug, you haven't given any neuromuscular drugs. So verify and confirm that. Number 2 is assess the depth of anesthesia with your BIS monitor, obviously. So see that you are not too deep. You normally keep it between the BIS monitors between 40 and 60. So make sure that the depth of anesthesia is adequate. Optimizing the mean arterial pressure is a one sure technique that can restore a lost signal. There are lots of papers stating that maintaining a high mean arterial pressure when you have lost the signal improves the scenario and restores the signal. Check and optimize the hemoglobin. If there is a drop in hemoglobin, transfuse the patient. Check and optimize blood pH and the PCO2, because as we have said, hypocarbia and acidosis can produce a change in the signal. Check and optimize the temperature, as hypothermia can also cause a loss in or a decrease in the signal. Now, what does the neurophysiologist need to do? He has to repeat the trial of intramuscular neuromonitoring to rule out any potential false positives, like we have said earlier. He has to check all leads and connections. He has to assess the pattern of changes, whether it is symmetric or is it asymmetric, whether it is the response is limited to one side of the body, lower half of the body, etc. Now, what does the surgeon have to do? He has to stop all manipulations of his surgery. He has to discuss the events just before signal loss. What really triggered the signal loss? Whether he has to discuss with the anesthesiologist as well as the neurophysiologist. He has to assess the field for any structural cord compression, examine osteotomy and laminotomy sites. And if there is, he has to check for any reversing actions that needs to be done. That is, whether he has to take out the screws or take out the rod or reduce the reduction of the spine. Now, after all these people have done these roles, an ongoing consideration if there is no interval improvement. Despite that, if there is still no improvement, we have to revisit the anesthetic and systemic considerations and ensure that they are all optimized. Consultation with a senior colleague is definitely helpful. You can administer methylprednisolone at 30 milligrams per kilogram IV. Consider wake-up test, because wake-up test doesn't have any fallacies compared to a neuromonitor, because neuromonitor is always equipment-related factors can be there. So those things are avoided in a wake-up test. And then you have to discuss whether we need to continue the surgery or stop the surgery and do a staging procedure. That is, you stop the surgery then and there, and then decide about doing a stage procedure maybe a week later. Now, this is a wake-up test. I'll just explain it to you. So in a wake-up test, what you need to do is you need to have a very good rapport with the patient. So you need to talk to them before you put them to sleep and tell them that they have to be familiar with your voice, because you will be the only one who will be talking to the patient while that patient is asleep. So when the patient slowly drifts off to sleep, keep talking to them and tell them to remember your voice, and tell them that halfway through the surgery, you will be telling them to clench their wrist, clench their fist, and move their legs. So that way, we are testing both the motor pathways as well as the sensory pathways. So here, what I've shown you is I'm telling the child to move the legs, to clench her fist and move her legs. And she's obeying me. I have just lightened my anesthesia, and this is what you see there. Now, what does the American Association of Neurological Surgeons think about neuromonitoring as such. Now, for its use as a therapeutic modality has only got a level 3 recommendation, meaning that there is insufficient evidence to suggest therapeutic relationship between the electrophysiological monitoring and neurological outcome. It is not recommended for this purpose. Its use does not result in improved neurological outcome even when intraoperative monitoring alerts occur. So you can't think that just because you have a neuromonitor, the outcome will be good. No, it doesn't mean that. So it has got only level 3 evidence for being a therapeutic modality. For a clinical relevance, it has got level 1 recommendation, where it says that SSCPs and MMP recordings during spinal cord or spinal column surgeries is a reliable and valid diagnostic adjunct to assess spinal cord integrity and is recommended if used for this purpose. So what are the take-home points? If there is an increase in latency of more than 10% and a fall in amplitude of more than 50%, it is significant. Responses that are stable initially, later showing variability of increase in amplitude or latency indicates a potentially developing lesion. Evidence-based medicine indicates relevance of neuromonitoring clinically, but not therapeutically. Thank you very much.
Thank you so much, sir, for your elaborate discussion on this neuromonitoring scoliosis. And you talked about starting from the history and physiology of the pathways and relevant applied anatomy and what is the ideal anesthetic agent to be used, and how we interpret this false signals and false negative signals and the checklist of IONM alerts in a patient with a stable spine. And okay, we can go to the next topic and we'll discuss it at the end, sir. And next speaker is well known to all. Is Dr. Pathasari sir. Is a multifaceted personality. And not only in anesthesia, is an MD of acupuncture, diploma in diabetology, PhD in physiology, RDA, and I had a website on painfreepartha.com. The website for the postgraduate, he uploaded so many hundreds of slides there. And he is a very versatile personality. And there is so much of interested in academics also. Have 145 publications and 445 citations. Apart from this, he is an very good Tamil poet, and he released poetry books, 7 poetry books in Tamil also. So this oxygen, the word, is almost known to all the laymen also after this COVID pandemic. Everybody will know about the word oxygen. So this oxygen therapy is most important topic, and every medical person should know about it, because oxygen is not a gas as what we think about it. It is a drug that should be prescribed in a legible way. And how much the fluid, what is the concentration, what is the duration of therapy, and how the device should be given, and what are all to be monitored. Everything should be written as a prescription when you start the oxygen therapy for this patient. So over to you, sir, for oxygen therapy devices. Dr. Pathasari, sir.
Hello.
Yes, sir. Audible.
Hello, am I okay?
Okay, sir. Audible.
Okay. My slides are visible clearly?
Yes, sir. Visible.
Okay. So, good evening, everyone. And my sincere thanks to the academic director of the ISA Pudukkottai and all the office bearers of the ISA Pudukkottai, chairperson of today's Pudukkottai Budan, my co-speakers, friends, delegates, a warm good evening to all. Okay, so today's topic is about oxygen therapy devices and tips for it. I'm not going to talk big things, small basic things, and many persons may think that, yes, we know all these things. Why he is talking like that? Sometimes People may think like that also. So whatever it is, I am going to talk very simple, basic things only. So this is our college, Mahatma Gandhi Medical College and Research Institute. And every time I talk anything on academics, I put a big salute to the legendary teacher of 2 centuries. Professor Ravi Shankar is currently the director of e-learning and Seed Dreams in Balaji Vidyapith University. So we may think, what is this oxygen therapy? Actually, what is this oxygen therapy? It is administration of oxygen at concentrations greater than 21%. This is what is oxygen therapy. Because we are taking in 21% from atmosphere. If we are able to be given something extra than this, then it is called oxygen therapy. Why do you want this? We want this to prevent or correct hypoxia. We want to prevent or correct hypoxemia, give oxygen at a concentration more than 21%. So J.B. Priestley named it as oxygen because oxy is an acid and genesis is production. Because if you give some gas, carbon dioxide like acid is produced from the respiratory system. So oxygen goes in and produces some acid. That is what he called it as oxygen. So when to give, there are a lot of controversies. Oxygen administration guidelines. So 2021, 22, so many things are there. But when to give is 60 millimeters of mercury is the partial pressure or saturation 90%. And infants, it may be 50 sometimes, it may be 85 sometimes. They may not need neonates 60 or 70 like that. So normally saturation 90% or the PO2 is 60. This is what you define as hypoxia. There was a question in MGR Medical University, second paper, define hypoxia. Everyone has written except this. It is a decreased PO2 less than 60 or a saturation 90%. This is what is the definition of hypoxia. Or when we think it is reasonable to administer, okay, we think that this patient is in mild pulmonary edema with some desaturation, the work of breathing is high, okay, we think it is reasonable to administer oxygen. If we come to the post-anesthesia period, all patients during emergence to prevent tissue hypoxia. So you can give for some time during emergence, but some factors favor prolonged therapy. Yes, this patient needs some more prolonged oxygen. For example, may need for a few hours, may need for 1 or 2 days. What are those factors? Doesn't mean all factors have to be put like that. Some factors may favor some prolonged therapy. What are those factors? Patient is having hypotension. Patient is anemic. Patient is hypovolemic. Still the process of correction is going on. Patient is in patient-controlled analgesia. Opioid infusions and sometimes on epidural morphines. So these are factors which favor. That doesn't mean all patients who receive epidural fentanyl should receive oxygen, something like that. All these things should be kept in mind whenever we prolong oxygen therapy in a post-operative period. Patient factors, elderly, shivering, we know because it increases the oxygen consumption even by the matter of 400%. So that is why we need oxygen in shivering. Upper abdominal surgeries, thoracic surgeries. So these are all pathophysiological factors, pain factors, patient factors, surgical factors. All these things can have, yes, we may think to go ahead with prolonged post-operative oxygen therapy. Sir, Kanan sir?
Yes, sir.
Am I going okay or speed is slow, fast?
Yes, sir.
Okay. So regarding oxygen therapy, there are classically described 4 types. Hypoxic hypoxia, cytotoxic hypoxia, stagnant hypoxia, anemic hypoxia. See, whenever we are treating hypoxia with oxygen, we think that this patient is having hypoxic hypoxia. There it is very useful. With regard to cytotoxic hypoxia, it is not at all useful. Where is it useful? In cyanide poisoning. Not at all useful. But in certain patients, anemic hypoxia and stagnant hypoxia may be used. So, whenever we are giving hypoxemia and oxygen therapy, we think only this cause as the prime reason. We are not giving anemia, PO2 is normal. We are not thinking circulatory shock. There are a lot of definitions, classifications and all. Myocardial infarction. Do they need oxygen? Most of this say no. So stagnant hypoxia may be useful or may not be useful. But what we target is the type of hypoxia is hypoxic hypoxia. What are the clinical clues? Now the patient is hypoxic. The saturation is 89. He may have tachypnea, he may have dyspnea. He may have tachycardia, he may have arrhythmias, serious, heart, lungs. He may have anemia, he may have restlessness. Many times you see, when there is hypotension, hypoxia to the brain, spinal, they are disoriented, restless, so many things they will tell because it is hypoxia. So others are cyanosis, clubbing, nausea and vomiting. Yes, we see in most of the spinals nausea after hypotension and hypoxia. So you can see here hypoxemia clues, pulmonary, heart, hematology, CNS, others. That means it is clueless. That is what we need to understand. There is no clinical clues for diagnosing. So why this patient? Sometimes we may be breathless, but we are normoxic. We don't have hypoxia. So those patients mostly don't need oxygen. So normoxic patient, sometimes breathless because of some other reason, need not need oxygen. Yes, there is a point of some amount of hypoxemia. The patient is 95. The work of breathing is high. He is normoxic. But there is something. Yes, this is what I told. When we think reasonable to administer, hypoxia means less than 60 millimeters of less than 90 millimeters saturation. But it also means when it is reasonable to administer. We also need right patient, right oxygen, right length of time. Now we know 1000 ml is supplied, 250 ml is consumed, 750 ml is returned, and oxygen flux is cardiac output into this thing. We know saturation is important in this. Now that is what is 60 millimeters, 90 saturation. This is what the descending danger. Ascending slope is so 90 kapra, if it falls down to something like that, the dip is so steep. The dip is so steep. That is what is the God's gift. 60, it's 90. If you go back, saturation is more important in oxygen flux. Go again. See, 90% we are able to get the saturation at 60 millimeters of mercury. If you go to 90 also, it doesn't matter much. It's around 96. This is what is the difference between oxy and deoxy, 4 oxygen molecules. So now what are we doing actually? Now 21% oxygen, 21% of 760 millimeters of mercury, that is 160. 21%. 21% of 760 millimeters is how much? 160 millimeters is the partial pressure. Now, if we go to dry atmospheric air, if we go to humidified oxygen, it combines with ideal. So all these things make it. This is what is called the oxygen cascade. When it reaches mitochondria, maybe 4 or 5, and if it goes below 2 millimeters of mercury, the mitochondria goes to anaerobic metabolism. That is what is called the pasture point of the mitochondria. Now you see this is the problem here. Now the problem is pneumonia. If we take an example, pneumonia. Now the pneumonia has to undergo red hepatization, green hepatization, gray hepatization, resolution, and etc. That will take 1 or 2 weeks. But now what we do is, we are not correcting anything here. We are giving oxygen and increasing 160 here to 330 so that your cascade is here and the patient becomes normal. So this is what we give and this is what we get the effect. We are not treating the hypoxia of red hepatization or anything like that. We are increasing this and getting the effect here. No arterial hypoxemia, but tissue hypoxia. Maybe there in infarction, some low output states, some hypovolemia, some cardiac failure may help. That is what I told, circulatory stagnant hypoxia. Now there are two terms, FdO2 and FiO2. FdO2 means the actual percentage of delivered oxygen by the oxygen delivery device. Now we have got a nasal bronch. How much is oxygen coming from that? It's 100% only. It's 100% only oxygen is coming out. Now what is the FiO2? If you keep it there, mouth or nose of the patient, what is actually the percentage of oxygen the patient is inspired? The device may give 100%, but the patient may breathe only 24%. Why? Because the device, if you have a nasal device and the patient is breathing through the mouth, there is no meaning. The oxygen flow, even with the same nasal prongs, if you keep 6 liters oxygen, your FiO2 is going to increase. Patient's efforts and flow, patient is breathing fast, your FiO2 may decrease. Minute ventilation, mouth breathers. So all these reasons make the difference between FdO2 and FiO2. We calculate and give, but it all depends upon all these reasons. So that FiO2 will change. Yes, I have a nasal bronch. If you give 4 liters, the book is giving 26% the patient. No, it may not be there because the patient's efforts may differ, mouth breathing is there. All these things may change your FiO2, even though your FdO2 is 100%. Now there are a lot of new classifications coming, but still we stick on to the old classifications of variable performance and fixed performance. What is that meaning? Reservoir and enclosure systems are different. Variable performance devices means the performance varies with the patient's flow rate. Now, nasal catheter, cannula, simple oxygen mask. Fixed performance means it will meet the demands. The flow rates may be 35 to 40 liters. That is Venturi mask and incubators. Now I will go back. Now the patient is breathing like this. You give a nasal cannula and you give 6 liters, it will deliver 26-28%, even 30%. But if the patient is giving a nasal cannula and the patient's flow rate is like this, now it will give only 23%. So this is what is called a variable performance device. The performance of the device with regard to giving a FiO2, it is not the thing, with regard to giving the FiO2 differs with patient's flow rates. Patient is normally breathing at 8 liters per minute, it is okay. Patient is breathing at 30 liters per minute. Your nasal bronch is not going to give the so-called set values. But if you have Venturi mask, yes, the flow rates may be 15 liters and another entrainment, everything comes to 16 liters or sometimes up to 35 liters. So that even if you breathe or the flow rate of 8 liters or with the flow rate of 18 liters, yes, it will match the demand. And the performance of the device with regard to giving the FiO2 to the patient is same. I am again coming to the same point. Now, if we have an FiO2 40%, Venturi mask, and you keep on 8 liters, and these 8 liters will combine to form some 30 liters or something into the air. And if the patient breathes at 30 liters also, it will give 40% oxygen. If the patient breathes at 8 liters also, the patient gets 40% FiO2. That is what is called the fixed performance device. Both systems can deliver a wide range of FiO2. Don't confuse. Because even with nasal cannula, if you give 7 or 8, 6, 7 liters, he may get 4%, 0.4, that is 40%. With Venturi also, we can give 28%. That doesn't, this is not to be confused. Low flow is different and low FiO2 is different. That means variable performance does not equate with low FiO2. Now we go to some examples of devices. This is the nasal prongs, nasal cannula. One, this is what is the routine thing, 6%. It's a variable performance, simple, well tolerated, available. Feeding can be done, mobility, the patient can talk. Humidification is not needed because it is going through the natural humidification process. We don't need nasal bronchial ones. What is the problem there? Nasal bronchial people will keep humidification. Not needed because the nose is there for the natural humidification. You see, sometimes you have to tie the knot slowly. Very distinct. It will be very discomforting for the patient, and he will say that I don't want this nasal cannula only. He will put the blame on the device because you have tied the knot strongly. This is a nasal catheter. Put the nasal catheter here because there is a reservoir here. You may achieve little higher flows. You may achieve little higher FiO2. Some reservoir is there, but this is the reservoir. That the stars, no, this is intus or the reservoir. But it is ideal to avoid suction catheters. These are mustache reservoir cannulas. This is pendant reservoir cannulas. 20 ml reservoir of oxygen may be there. Use nasal cannulas in conjunction with air-driven nebulizers. Yes, this is what is the problem. So many times in asthmatic patients, nebulize பண்ணும்போது we connect to oxygen and nebulize. That will completely distract the FiO2s, completely confuse. What you should do is air-driven nebulizer, you give the drug, and in between you also give a nasal drops. Okay, that means you are giving an FiO2 of 30 to 35%. That is okay for an asthmatic. Transtracheal catheter in hospital, sterile percutaneous transtracheal insertion. This is more for home care. Sometimes we may not know what is Bluetooth or oxygen. A simple oxygen mask. This is what we use. A plastic reservoir. Designed to fit over the, no, this is a plastic reservoir. Internal capacity is the reservoir. Sometimes it may be 50 ml, 30 ml, 25 ml, depending upon the size of the mask. But high flows, high FiO2 is possible. Patient cannot eat and he may not speak. But short periods is okay. Humidification is okay. Holes, there are holes you can see, no? These are holes. Simple oxygen mask is a variable performance device. If the patient breathes fast like this, the air will go from here and not from here because this will flow rate is 1 minute, sir. Sir, meeting like an hour, 10 to 20 minutes. Meeting like a Pondicherry. High flows, high FiO2, possible short periods, humidification is here. You can see if the patient, this is giving an oxygen mask. We have said 4 liters, and this is giving 4 liters. If the patient breathes at 8 liters, what will do? He will inhale from here. This will also serve as an inhalational port and also as an exhalational port. The partial rebreathing mask. Now you can see here, the oxygen will go here and fill it up, and the patient will take in air. There is also a hole here. If the patient is not able to, if this reservoir bag is not able to cater to the needs, he may use this entrainment port. So you may high 60 to 80% is possible with partial rebreathing, but patient exhales through this and also inhales through this. If the flow rate is not matching, understand this is a partial rebreathing mask. There is a gap here. This serves as an entrainment on exhalation. If the flow is not adequate, he will inhale through this and he will exhale through this. Non-rebreathing mask, these are one-way valves. See here, this is a valve. The oxygen goes from here to the bag, and the patient has to take from this 100% oxygen only. If you have these things as very fit. If this is not fit, then your oxygen may not be there. So this is the one-way valve. He has to exhale through this, and he cannot entrain inside. He has to breathe here. That is why sometimes 100% FiO2 is possible if there are no phase leaks. Now this is available everywhere, everyone now. 1,000 rupees, now it has come to 600 rupees or 300 rupees, sometimes 250 rupees also. High flow aerosol. Oxygen is forced to a jet orifice, entrains both room air and gets humidified from bottle of adapter, goes through a brick cylinder. High flows, fixed FiO2, noise is there. See here, this is what is the high flow aerosol. Now we will go to high flow systems. Air entrainment most commonly used is Venturi, 0.24 to 0.6%. That is 24 to 60%. Normal is 21%. Okay, room air. Now here you can see this is the oxygen thing, and the air is entering from here, and the oxygen goes like this. Now this is 6 liters. Sometimes 16 liters will come here, and 22 liters will go. This is what is the high flow systems. 22 liters flow at air. If he breathes as 15 liters, or if he breathes as 20 liters, or if the patient breathes at 6 liters only, the FiO2 is not going to change. That is why it is called fixed performance device. We may need to have a small connector, because in theory, if you keep like this, the patient will be very much discomfortable. There is a lot of noise, sound here because of the entrainment, and so that the patient will feel discomfort. So we need to have a small connection tube between the venturi and the mask. High flows, patient's inspiratory flow much, hence FiO2 is controlled. Fixed FiO2, very ideal for dyspneic and distressed patients. Yes, I'm again telling, don't confuse low flow with low FiO2. Even with venturi, even with 15 liters flow, we can keep 26% also, 40% also, 60% also. Uncomfortable for extended, unable to measure FiO2. What is the major problem with this? There may be some secretions here blocking, or there may be secretions here blocking. Yes, we have kept on venturi. This is what is the major problem in corona. If you have kept a venturi and the patient saturation falls, we never think of this common causes. We go back again to 100%. What is it? Non-rebreathing bags. So very common to have secretions blocking this or blocking this. This is what? Yes, dry secretions. There is no secretion to block these things. There is also one thing, it will come. The oxygen will not travel in wet secretions. It will come again. Calculation of air entrainment ratios is given in all books. So I am going away from this. There is something called GIN, that is Pondicherry Special Gas Injection Nebulizer. Here you can see it is also available online. Pneumatic nebulizer, no entrainment, 2 flows, up to 40 liters is possible. 21% to 100% is possible. This pulse demand oxygen delivery. When we inhale the burst of oxygen, no wastage. That is what is in monitoring and long-term oxygen users. Nightly oxygen patients, we can use this pulse demand oxygen delivery. Patient inhale pannaboda, there is a valve opening, oxygen will flow in. Exhale pannaboda, wastage of gases will not. So that is what is called mainly used in flying. Oxygen hoods, transparent enclosures designed to surround the head of an infant. Here you can see hood. A minimum, yes, very important is minimum liters. Many times the hood or a capacity we may need to give the flow. Hood or a capacity 3 liters, we may need to give 3 liters. Many times you can see in nursing homes, hood is 7 liters and you give 2 liters flow, which is of no use. Instead, we need not give only. Dangers of oxygen therapy, somebody is going to talk. I am going to tell only the dangers or the physical problems already told because instrument may break, an instrument may hit or injury. All these things are physical problems with this oxygen therapy devices. We have enough oxygen, but what we need is all these things. If we don't have these things, sometimes in smaller places, peripheral setups, all these things matter much than cylinders and cylinders of oxygen. Yes, if we don't have problems, we can use this, but we need to have constant current supply, and usually we need to connect with this inverters. Factors that determine which system to start use. Kannan sir, I'll finish in 5 minutes. Is it okay?
Okay, sir.
Okay. Patient comfort, distressed or normal, level of FiO2, level of humidification, nebulization, all these things. Patient is normal, comfort or distressed. What is the level of FiO2 needed? Do they need humidification? All these things matter when we start giving oxygen. Oxygen cannot travel in wet secretions. This is another thing that has come up new, high flow nasal cannulas, completely modernized the corona treatment, which can give 50 to 100 liters. What is more important is sometimes ventilation is possible. We should understand the two things in respiration. Number one is oxygenation. Number two is removal of carbon dioxide. This removal of carbon dioxide is called ventilation. So these many devices give oxygenation. So high flow nasal cannulas can also make ventilation possible. We will go to case scenarios. An acute asthma comes with respiratory distress. These patients are hypoxemic, rapid respiratory. Now, if there is no CO2 retention, rapid respiratory, flow rate is high, we need venturi mask. We need humidifications. So this is what humidified venturi masks are needed because dry gases can increase passage. So you need high flows. Now there is no use of giving some nasal prongs for these patients because the flow rate of these patients are 16 liters, while your nasal prongs will be only 2-3 liters. A case of pneumothorax with respiratory distress, 100% oxygen we may need. In distress, you can use gas injection nebulization. If not in distress, we can use non-rebreathing mask, NRBM. Yes, face tight NRBMs. A routine post-op laparotomy patient, a small venturi cannula or a nasal cannula, small FiO2 of 0.3 is usually enough. And in fact, there are a lot of doubts about whether we can give oxygen, whether there is needed or not. Nasal cannula or catheter is started. This will not hinder talking or drinking by the patient as opposed to mask. Use a small cannula, give some 4 liters and let it be 0.3% or 0.35%. A case of facial-maxillary trauma, there we cannot put a nasal catheter. That is what is very important. An infant with a croup needs humidification. So croup means humidifications. A COPD patient, a FiO2 of 40% oxygen, patient conscious slowly deteriorated. ABG showed PaO2 of 80, PaCO2 of 75. The patient now clearly telling, I am losing my hypoxic drive. Hypoxia irundhacha, I will start moving my breaths and wash out carbon dioxide. If I lose this hypoxic drive, I may retain carbon dioxide. That is what is the problem with giving oxygen. Ventilation is a different thing. So patient slowly goes for carbon dioxide narcosis. Now get down your PaO2 to 60 millimeters. Get down your PaO2, sustain some hypoxic drive to wash out carbon dioxide, or otherwise you may need to go for an IV. Supplemental oxygen may not correct all hypoxias. We may need to correct ventilation. We may need to give CPAP. We may need to give blood. All these things are needed. Everywhere hypoxemia, oxygen may not be helpful. Sometimes patients themselves beautifully holding the mask. Oxygen is a drug. Staff give oxygen, nothing. Continuous humidified oxygen, venturi mask, 40%, 8 liters. Nasal, unhumidified oxygen, nasal prongs, 3 liters. The prescription should be like this. Thank you. Thank you all.
Thank you so much, sir, for your elaborate, excellent lecture. It is a eye-opener for most of the postgraduates regarding this oxygen therapy and oxygen therapy devices. Very excellent slides on the presentation, sir. Thank you so much. And then next we move on to the next topic, oxygen toxicity. And that is presented by Dr. Divya Saran, who is our resident of our Department of Anesthesiology in Medical College. Is having hobbies in writing poems also. And oxygen is a drug that should be prescribed, and it should be give the drug as lowest effort as possible to the patient. And if it is more than high concentration of oxygen for more of the time, it will also create so many problems. And now over to Dr. Divya Saran regarding this topic on oxygen toxicity.
Good evening, everyone. Thanks for everyone for providing me this golden opportunity. I am here to present oxygen toxicity. What is oxygen? Oxygen is the gas that sustains life. But when oxygen is given in a higher quantity, or when oxygen is given at a lower quantity for a chronic period of time, it can lead to oxygen toxicity. So what is oxygen toxicity? So harmful effects of breathing molecular oxygen at an increased partial pressure can lead to hyperoxia. So hyperoxia means an excess of oxygen in the body tissue. So it can result in cell damage and cell death. The adverse events due to oxygen occurs due to increased oxygen tension in the alveoli, blood or cellular level. So when does oxygen toxicity occur? It can occur at two factors are dependent on oxygen toxicity. One is pressure and time of exposure and partial pressure of the oxygen. So it can occur either at normobaric normobaric level or hyperbaric level, and based on the time of exposure and the partial pressure of the oxygen concentration. So in if the FiO2 is given more than 60% for 36 hours, oxygen toxicity can occur. And the FiO2 is given for more than 80% for more than 24 hours, oxygen toxicity can occur. FiO2 when given at 100% longer than 12 hours, oxygen toxicity can occur. So who are the high-risk groups for oxygen toxicity? First, infant and neonates getting 100% oxygen for more than 2 to 3 hours, premature babies, long-term ventilation with high FiO2, and then chemotherapeutic agent like bleomycin, hyperbaric oxygen therapy, and underwater divers. So there are two types of oxygen toxicity, chronic oxygen toxicity and acute oxygen toxicity. Acute oxygen toxicity means very high concentration of oxygen given at more than 1 atmospheric pressure for a brief period of time. Usually the acute effects of CNS are predominantly CNS manifestations. In chronic oxygen toxicity, lower concentration of oxygen given for a longer duration. The chronic effects are predominantly pulmonary manifestations. Of oxygen toxicity, the most important one is absorption atelectasis. When high concentration of oxygen is given, pulmonary atelectasis occurs in the area of low V by Q ratios. Atelectasis occurs because the entire nitrogen is washed out of the lungs. Nitrogen, being a gas with low solubility, in its presence, it acts as a splint and thereby it supports the alveoli and delays collapse. But in absorption atelectasis, due to decrease in the lowered pulmonary gas tension in the pulmonary capillary blood, there is an increased uptake of alveolar gas and thereby causing nitrogen washout from the lungs, leading to absorption atelectasis. So in this picture, in lung A, the nitrogen is completely washed out, and due to that, the alveolus could not maintain the patency, and there is airway collapse. It leads to absorption atelectasis. So how does oxygen is metabolized? The metabolism of oxygen takes place at the end of the electron transport chain in mitochondria within the cytochrome oxidase complex, where the electrons that accumulate as a result of ATP generation are cleared by chemical reduction of oxygen to water. In simple words, the oxygen is reduced to water and the electrons produced from the ATP generation are utilized here. So oxygen has two outer orbital electrons. So it cannot be converted to water in a single electron reduction step. So there is a series of simple reduction steps which lead to convert oxygen to water. The radicals formed during this process are called as oxidants. The most common are superoxide radical, hydrogen peroxide, and hydroxyl radical, of which hydroxyl radical is the most powerful oxidant. So what are antioxidants? The atoms are molecules that prevent or block the actions of oxidizing agents, of which glutathione is a major intracellular antioxidant. Other antioxidants are catalase, superoxide dismutase, vitamin C, and vitamin E. So of which the glutathione, being a major anticellular oxidant, it converts hydrogen peroxide to water in a reaction catalyzed by selenium-dependent enzyme glutathione peroxidase. This is the reaction in which the hydrogen peroxide is converted to water by selenium-dependent glutathione peroxidase enzyme. It does not allow the formation of hydroxyl radicals. So what are oxygen-free radicals? When the oxygen is utilized in cellular respiration, of which the majority of oxygen is utilized by mitochondria for generation of ATP. So in electron transport, oxygen is reduced to its ionic form for ATP generation. These toxic levels of O2 will lead to the formation of reactive oxygen species. These radicals will decrease the contractile force of the heart and increases the peripheral vascular resistance and systemic vascular resistance. In general, hyperoxia, when there's an excess oxygen in the body tissues, it will lead to acute pulmonary injury, which is caused by hyperpermeability of the pulmonary vasculature. It mainly leads to pulmonary edema, abnormalities in coagulation, and fibrinolysis or fibrin deposition. So due to reactive oxygen species, only there are 4 steps. One is DNA damage, and there is decrease in signaling, and the third is protein oxidation, and fourth is lipid peroxidation. The DNA, because of the DNA damage, there is increase in cell death, oncosis, apoptosis, and decrease in proliferation of the cells. And in signaling, because of decrease in signaling, there is a decrease in angiogenesis, and there is neuroexcitotoxicity. And because of protein oxidation, there is decrease in the enzymatic functions, and there is growth factor inhibition. Because of the lipid peroxidation, there can be increased inflammation and increased free radical formation. So now we are coming to Lorentz-Smith effect. This was first described by Lorentz-Smith in 1899. When he was experimenting in mice and birds at 0.43 bar of oxygen, it had no effect. But when the oxygen was given at 0.75 bar of oxygen, it acted as a pulmonary irritant, because when he was trying to experiment, he found there was a fatal pneumonia in mice and birds, while oxygen was given at 0.75 bar. So what are the main pulmonary effects? There are 3 phases in pulmonary effects. First is tracheobronchitis, and then comes the ARDS, and then comes the pulmonary interstitial fibrosis. In case of neonates, the bronchopulmonary dysplasia can occur. What are the clinical features of the oxygen toxicity? So in non-aerobic O2 inhalation, even within 6 to 8 hours, it can cause pulmonary changes. It decreases the tracheal mucus velocity when normobaric oxygen is given at 6 to 8 hours. In 12 hours, that can be non-specific respiratory symptoms. When you give the oxygen for 24 hours, there comes the pulmonary function changes. Pulmonary function changes can also occur at 3 to 5 atmospheric pressure. So what are the clinical features of pulmonary toxicity? The most early symptoms are coughing, pleuritic chest pain, carinal irritation, and hemoptysis, dyspnea, mild tickling sensation on inhalation, rales, fever. Chest X-ray shows the signs of inflammation and pulmonary edema. So next comes the CNS toxicity. So CNS toxicity was found by Paul Burt in 1878. So it was when he was experimenting in logs, he found when oxygen is given at a higher pressure, it gave oxygen caused convulsions in logs. So thereby oxygen toxicity was found. It also showed oxygen was toxic to insects, fungi, germinating seeds, birds, and other animals. So what are the early symptoms of CNS toxicity? Acute CNS toxicity occurs at a pressure above 3 atmospheric pressure. The initial symptoms are twitching of perioral and small muscles of hand, and followed by facial pallor and cogwheel breathing. If the exposure is continued, vertigo and nausea, followed by altered behavior, clumsiness, and final is convulsion. So convulsions begin with the loss of consciousness. It also occurs in 3 phases. First is tonic, second clonic, and fourth critical phase. So tonic is generalized hypertonus lasting for about 1 minute. Clonic phase with a convulsion for about 2 to 3 minutes. Post critical phase for about 10 minutes. The patient has no memory of the crisis. In case of hypercapnia or exercise or a cold environment, it can increase the cerebral vasodilatation, thereby increasing the oxygen delivery to the brain, and thereby it can increase the CNS toxicity. So CNS O2 toxicity is an acute exposure to an oxidative environment that depends. In consolidation, the effects are visual changes, nausea, facial twitching, behavioral changes, dizziness, and seizures. So next comes the ocular effects. So the ocular effects are myopia, cataract, retinal detachment, and the retinopathy of prematurity. Myopia is progressive due to oxygen toxicity, but it is reversible. Both myopia is reversible, and cataract, when prolonged exposure is present, cataract formation can occur. The major important thing in ocular effects is retinopathy of prematurity. When an FiO2 of 0.4% is given around for 6 hours, the premature infants and babies babies are very sensitive to oxygen, it can lead to neovascularization. Neovascularization is called as retinopathy of prematurity. It is a neovascular retinal disorder that develops in premature babies. Incidence of retinopathy of prematurity is high when unmonitored high more than 0.5 FiO2 oxygen is administered to premature babies. The recommended arterial oxygen concentration for premature babies receiving oxygen are 50 to 80 millimeter of mercury. So what is the safe FiO2 level? No health effects when the oxygen is given at 50% of FiO2 for 24 hours at 1 atmospheric pressure. When it is given at 50% of FiO2, there is no adverse health effects. When does the lung function get affected? When the oxygen is given for 2 to 6 hours at a pressure more than 1 atmospheric pressure, there is reduction in the vital capacity, reduction in the lung function. So when does CNS toxicity occurs? When the oxygen is given at a pressure more than 2 atmosphere. So for premature babies, when oxygen is given at a 40% for 6 hours, there will be retinal damage. So how do we prevent the oxygen toxicity? Oxygen toxicity must be, the management is purely symptomatic, but more than managing the oxygen toxicity, it is better to prevent oxygen toxicity. Prevention is better than cure in oxygen toxicity. So adequate monitoring of oxygen therapy must be there. When we find there's an oxygen toxicity, the abrupt stoppage of oxygen will, at the onset of toxicity, will aggravate the symptoms. It's called as oxygen off effect. So the most common indicator of pulmonary toxicity is the reduction in the vital capacity. So how do we monitor the pulmonary oxygen reduction in the vital capacity? So there's a theoretical concept called unit of pulmonary toxicity dosage, which predicts the extent of pulmonary damage with the complicated and prolonged therapy. So 1 minute of 100% oxygen at 1 atmosphere is 1 unit of pulmonary toxic dosage. So it will take 1425 unit of pulmonary toxic dosage to produce 10% reduction in vital capacity. This 10% reduction in vital capacity is acceptable. So when there is a 10% reduction in vital capacity, we must be careful and monitor for oxygen toxicity. Whereas EEG has no value in monitoring oxygen toxicity. So what is the take-home message? Oxygen is a drug and it should be used judicially. Management of oxygen toxicity is purely supportive. Prevention and monitoring and for early recognition is important. Causative problem for hypoxia should be identified and it must be intervened appropriately. Giving O2 alone is not a solution. Close monitoring of patients on O2 therapy. Final message, oxygen is always a drug and should be used judiciously. Thank you for giving me this golden opportunity. Thank you.
Thank you so much, Dr. Divya Saran, for your nice presentation. I think this may be your first virtual presentation, I think. Okay, I think it is good also. Oxygen is very vital for survival. At the same time, it is a double-edged sword. It will kill the patient also. If it is not used in correctly and judiciously in a correct way. And most of the oxygen therapy, if it is given in more than 1 atmosphere, it is very dangerous. You have to be very careful. And you have to monitor the patient very keenly, otherwise there are so many problems. Sometimes it will kill the patient. And the CNS toxicity of tumor and this are inevitable. Even in more than 4 to 6 atmospheres, hyperbaric oxygen therapy. But in case of chronic toxicity, there is FiO2, higher FiO2 for a long period of time. Okay, now it is now time for discussion. And coming to the first speaker, that is Dr. Sir, you are audible, sir?
Yeah.
So, on question for
I didn't get the question.
Sir, backup test is essential in all school action. It is essential. Can you be audible, sir?
Hello.
Stefan.
Pass.
Sir, the question is audible, sir. Regarding the demonstration
Audio echo.
in your radio. Well, the wake-up test is essential in all scoliotic accentuation, sir.
Sorry, what's the question?
The wake-up test
Yeah.
is essential in all scoliotic accentuation.
No,
Is the question in the chat box.
wherever you have a neuromonitoring facility, that needs to be used. But we should always have a wake-up test on the background, because the neurophysiological test is a mechanical one. Like I said, there can be a lot of false positives and false negatives can happen. So if you have a backup as a wake-up test as a backup, it is one sure test that the integrity of the nervous system is intact. So we always have both in mind. So even though we monitor the neurophysiologist, we always tell the patient that we might wake you up in the middle of the surgery and do a wake-up test. So it's good to have a backup as a wake-up test.
Sir, in your experience, what are the problems you have anticipated or you have experienced in doing this wake-up test in the patient? In the middle of the surgery, you are waking up the patient.
Yeah.
What are the problems you have experienced,
sir? Touch wood, I haven't had any major disasters during the wake-up test. Only thing is, you should be cautious so that you don't lighten the anesthesia too much. If you lighten the anesthesia too much, you might, the patient might really, because the patient is prone, they might really jump out of the table. So you have to titrate your doses accordingly. You tell the surgeon that he needs to let you know at least half an hour before that he is planning for a wake-up test. If the surgeon says he wants a wake-up test, he should let you know at least half an hour before the proposed time, because you have to gradually titrate the dose of the drugs, because suddenly if you reduce the drugs, patient might literally be coming out of the anesthesia, and all the lines and tubes might be displaced. So always have a good rapport with the surgeon, and if he anticipates a problem and he wants a wake-up test, get sufficient amount of time and titrate your drugs slowly.
Sir, I am Dr. Meenakshi Sundaram, who has asked that question. Sir, you have given a wonderful lecture and a demo also. But what I want to ask you, even if the surgeon informs us half an hour earlier, all the doses which we are using, this becuronium mainly, it is going to last for half an hour only, because we will be using a lot of fentanyl and some inhalation agents to block the awareness. So now the top up dose will be very minimal only. So instead of allowing the patient to wake up in the middle of the surgery, and again it is very difficult to take back the patient on anesthesia, and you say you slowly titrate and don't allow the patient to awake so much. Don't lighten the anesthesia too much. But practically, how we can decide? It differs from patient to patient. So with the inhalation agent, we have to reduce, and we cannot predict really if we are asking the patient to do something. And if the patient is not obeying, it may be due to anesthesia or really there is a nerve affected. It is very difficult to predict. So the second question subsequently asked whether this SSEP can completely replace that wake-up test. I wanted to ask, because it is practically very difficult. I don't know how it could be done in all the places. That wake-up test, awakening the patient in the middle of anesthesia, and again going back, as you say, the patient is in a prone position. And if the patient even strains at the endotracheal tube, it will create a lot of damage. So even if people practice, they should be very careful. And I want your experience in that.
Yeah. It is really an art to do a wake-up test. Okay. Because most of my colleagues or my postgraduates have never seen a wake-up test. They've just heard of a wake-up test. Okay, so it comes with experience, because you titrate it based on your BIS monitor. So you know how much the patient is
right.
waking up. BIS monitor is one thing. Then SSCPs can't say that your motor pathway is intact. So SSCPs will tell you only about the sensory tracts. So it can't replace the wake up test. So the amount of drugs you give, the titration all depends upon one is your judgment of how light the patient is, and having a good rapport, because I have done many wake up tests, and at times when the neuromonitor was faltered, the wake up test told us that everything is fine. So it is a good asset to learn to titrate the drugs. I cannot tell you exactly at what level each patient will wake up. So it is actually a skill that you develop over the years. Yeah.
So in a nutshell, sir, as you, sir, 1 minute, as you are monitoring,
yeah,
as you are monitoring BIS, I think if at all you want to do a good wake up test, it can be practiced only in places where they have BIS monitoring.
Yeah,
clinically,
exactly.
Clinically, it is all the more difficult. As you see, the PGs have not seen that. Honestly, I have not seen that.
Yeah, yeah.
So you are versatile in that. Thank you very much.
Yeah, thank you very much.
And one question, sir. You are not giving muscle relaxation to the patient. You are giving total intravenous anesthesia for this patient.
Yeah.
Whether the surgeons are really comfortable without giving muscle relaxation to this major surgery.
Exactly. I mean, without muscle relaxant, you need to stay around. My surgeon, without muscle relaxant, he needs approximately, depending on the length of the scoliosis to be done, approximately 3 to 4 hours without muscle relaxant. So you have to keep it so deep with your propofol, your Dexmed, and your fentanyl. Because once he starts putting the screw, every time he stimulates he wants the stimulation to know whether the nervous system is intact. So if you keep giving muscle relaxants, then the duration of the surgery will get prolonged from 3 hours to 12 hours. So that is also a skill to manage by avoiding the muscle relaxant. So my surgeon hasn't had any problems with the amount of relaxation he needs with the TIVA, because I have never used volatiles because of the reasons I gave. So it is a totally intravenous technique, and it works quite well, surprisingly. I don't know.
Okay, sir. We are because the patient is on prone position. To make the patient immobile, we are not at all so much experienced with this PA for a whole of 3 hours surgery without giving muscle relaxation. That is why I am asking this question to you, sir.
Yeah.
Thank you, sir. Thank you.
Thank you. Thank you.
And next question to Sir Dr. Pathasari, sir, versatile personality, multifaceted. Because here there are so many TVs are joined here. You are talking about this oxygen curve. There is oxygen dissociation curve. It is sigma shaped curve. You said that. And why it is sigma shaped, sir? Can you explain this for the benefit of the TG, sir?
Which one, Dr. Chairperson, sir? Please ask the question again.
Why this oxygen dissociation curve is sigma shaped or dumbbell shaped?
No. See, actually, Dr. Parsardi has left for a neuro case. He is on duty. So, sir is not available. But the thing is, why it is in sigma shape only? It is a nature's gift. You are asking about ODC. It is a nature's gift, so that a reserve of 750 ml is allowed. So that even if we increase our metabolic demand, that 750 will act as a buffer. So it is a nature's gift. Everything is gift. Even 2 kidney, 2 lungs, everything is a gift. One is additional. Dr. S.G.K. Murthy has raised the hand. Dr. Shilpa, can you unmute? A1 Logics. Sir, Dr. S.G.K. Murthy, sir, can talk. Somebody raised the hand. Sorry for the interruption, Chairperson. You can proceed.
Okay, and next question, sir, possibly regarding this how many oxygen toxicity patient have you seen in your clinical practice?
That is myself only. He has left. Because see, what I wanted to convey, oxygen toxicity, first you have your eyes do not see what your brain does not know. So most of the times oxygen toxicity goes unnoticed. We will be treating it for labeling it as some other diagnosis. That is the reason why another person, Dr. M. Dakshinamurthy, has made a point. During COVID era, we have used oxygen right and left, and we are unaware of the oxygen toxicity. That is a point actually, because even the patients have increased the flow rate on their own during night hours, fearing hypoxia will kill them. We have exhausted so many oxygen cylinders we have seen because the patients automatically increase the flow to 12 to 14 liters, mainly during night time for fear of hypoxia. So they are not aware. So I have given even a lecture. It may even kill, then only they have reduced the thing. So Dr. Parsardi has made it very clear. It should be prescribed. That's what all the other anesthesiologist opinion also. Oxygen should be prescribed. So he's not there to answer the question.
Okay,
So we
sir.
will take Dr. Parsardi's question, sir.
What in case of cyanotic failure for surgery? Please ask Mr.
What is the
Muthukumar.
thing? Where you are reading, we could not read. What is it?
Sir, is the oxygen toxicity related to PO2 just PaO2 or just FiO2? And next
Which one?
question is, sir, it's a question from Muthukumar.
What is the question?
Is the oxygen toxicity related to PaO2 or just FiO2?
It is related to PaO2 only. It is related to PaO2. What is the thing? Because FiO2 cannot determine the PaO2. He has mentioned it very clearly. The FiO2 determines the PaO2 depending upon the patient's variability. So really PaO2 will kill the patient or produce oxygen toxicity and not FiO2. Whatever, even if you give 100% FiO2, if the patient is not breathing, it is not going to produce oxygen toxicity. It is only the PaO2 creates problem.
Another question is there, sir, in that, Muthukumar. What in case of cyanotic failure for surgery? The question is not incomplete. I cannot able to understand the question, sir. What in case of cyanotic failure for surgery?
What is the thing?
What in case of cyanotic failure for surgery?
I could not get the question at all.
Yes, sir.
Where you
the
are
same
reading? I
problem.
cannot see anything in the chat box.
Yes, sir. It is there, sir.
It is not in the chat. What is the question?
Sir, what in case of cyanotic failure for surgery?
See, cyanotic heart disease means again, you are asking about cyanotic heart disease.
I cannot able to get the question, sir.
Then
What is
ask
the-
Dr. Muthukumar to put the question clearly or allow him to talk.
Sir, Muthukumar is there. Silpa and logistics to unmute Muthukumar and
Sir, good evening,
Ah,
sir.
Please
I'm
tell
Dr.
me.
Muthukumar. Sir,
Yes, sir.
when there is a cardiac patient with the cyanotic heart disease and
Yes.
we need like a tetralogy of fellow or something, we need to give 100% oxygen and we have to keep up the PaO2 like say at least SpO2 when you are monitoring, you have to keep it around 85 or 90 and the
60.
PaO2 around
Yes.
60. Will that FiO2 or will that what we delivering 100% oxygen? Will it cause
Correct.
toxicity?
See, it will not. I get your question, Dr. Muthukumar.
Thank
It
you,
will not produce any problem. As you said, in cyanotic heart disease, because of this tetralogy of Fallot, you are giving 100% of oxygen when the baby suffers from cyanotic spells. It will not produce oxygen toxicity for the simple reason it cannot increase the oxygen partial pressure. It cannot do that because there is a shunt. So it will not produce any problem in that. And again, oxygen toxicity occurs only if the patient inhales 100% oxygen more than 3 hours, even acute oxygen toxicity. So it cannot happen with the cyanotic child.
Thank you, sir. Thank you, sir.
And sir, another question in the chat box, sir. In COPD with PaO2 of just 50 millimeters of mercury, whether should we supplement oxygen or not?
Again, see, the limit is 60%. The limit is 60% basic minimum. So you can increase up to PaO2 of 60, but increasing PaO2 more than 60 in a COPD patient, we should be very careful because they are prone for carbon dioxide narcosis.
Thank you.
I thought. Okay, sir. well, sir. And another question in the chat box, sir, clearly explain UPTD to Divya Saran. UPTD. What is it?
Unit.
UPTD.
The UPTD is a theoretical concept. It explains unit of pulmonary toxicity dosage. Normally, in 100% oxygen, when given at 1 atmospheric pressure, it equals to 1 unit of pulmonary toxicity dosage. So, to create pulmonary toxicity, there should be 1425 UPTD must be given, sir. So, it will cause 10% reduction in the vital capacity of the patient, sir. So if there's a 10% reduction in vital capacity, we must be careful that there is oxygen toxicity.
Chairperson, sir, I have mentioned, she has explained it very beautifully, but it can be calculated only by artificial intelligence and not by natural intelligence. AI has to be incorporated in the oxygen delivery system, or else it is very difficult to decide.
And one question, sir, from my side. Sir, Patrick sir mentioned about GIN options therapy device, sir. What it is, sir? We are not exposed with this GIN.
See, it is a jet, yeah. It is available in Mahatma Gandhi, so he has mentioned it. It is a jet injector device. It will be very useful when you are giving oxygen for a hypoxic patient who in addition requires nebulization also. So it is just like a jet injector. Imagine a Sanders jet injector we use for jet ventilation. It will give a pulse oxygen therapy. It is not available everywhere.
In that, she mentioned that there is no entrainment of air in this device, sir. In
Yes.
jet or everything else, there can be entertainment of air.
There is no air entertainment. See, it is very simple. There is no air entertainment because it delivers in a jet concept. See, only a flow can entrain oxygen. It is a jet. Jet is only periodical pulse. It is pulse generated. Like your, see, if in a Sanders injector, air entrainment is possible because in a larger tube, you are inserting a jet cannula. So the remaining orifice can do that. But here the jet injector can inject it is injecting the oxygen only in the natural orifice. So you cannot call it as a air entrainment. In GIN, it is popularly known as jet injector device. So they call it as GIN. It is not possible.
We have not seen that device. We have not seen the device.
He has shown the diagram.
He showed the diagram, sir. But in high flow, it's possible with this GIN device. Without air entrainment, more than 40 liters per minute is possible in GIN device. How it is possible, sir?
See, now
without entraining air, sir.
Yeah, that is right. See, in Boyle apparatus, by opening the bypass, without that is a bypass switch, it delivers 35 liters per minute. It is not doing any entrainment. See, it is a force with which it is delivered. It is flow with the velocity. It is a flow with the velocity. So it delivers like that. That is the reason why it is called a jet. See how jet flight in the flight, jet is supersonic jet is also available. That is the reason why it is called as jet. He has projected the diagram also. We will send the YouTube link tomorrow morning. So you can again see the entire lecture. You can see the jet injector device. Right now in the night itself, I can send you the link, the YouTube link for all the people. You can go through that.
Sir, one question from myself, sir. Regarding this hyperbaric oxygen therapy, we have not seen that hyperbaric oxygen therapy devices in anywhere else in service. Do you have the experience of this hyperbaric oxygen therapy, sir? And,
don't worry, I don't have any experience. I have not seen any hyperbaric chamber. I think I have more experience than you. In the years of anesthesia practice, I have not seen.
Okay. And thank you, sir. Thank you, sir. There is no more questions in the chat box, sir. All the questions are discussed, sir.
So I have to congratulate all the speakers and the chairperson because our time is 8. You are finishing it by 7:59. It is a fantastic time schedule. The chairperson has conducted the proceeding very well, and all the 3 faculty cooperated with him. Nice discussion also. All the people, all the 3 have done a wonderful job. especially the wake up test. He has shown the demo. Now only I am seeing it for the first time. What is the wake up test? And many people have mentioned, I have received personal messages also. He has done a wonderful thing. So now he has given a trailer. People will be waiting for the main movie next week. How you are doing that, sir? Your job is much more serious now because people are expecting more from you. Now the way in which I got the messages, Dr. Parsardi, he is a versatile speaker and oxygen is just his lover. So he loves so much. And I am very happy that he has given all the points which I am thinking in my mind. But unfortunately, I am not a speaker, and it is fortunate for you. And Dr. Divya, even though she's a budding star, she has done a complete justice. And I wish in this university exam, she should get a question on oxygen toxicity. So she will perform very well. And she has done a nice homework because in the UPTD, she has mentioned very nicely. And I hand over the session to our president, Dr. Suresh Kumar.
Thank you.
Over to you, sir.
Thank you, Dr. Elam sir. A nice lecture today. I thank our chairperson for conducting beautifully today's webinar. Now I call upon our treasurer, Dr. David, to propose the vote of thanks. Over to Dr. David.
Yes, sir. Good evening. Good evening to all. On behalf of ISA Pudukkottai, first of all, I would like to thank our academic chairman, Dr. Elam sir, for successfully conducting 32nd webinar. Thank you very much, sir. And I would like to thank today's chairperson, Dr. Kannan Bojraj, Professor and HOD, Government Training Medical College, Tamil Nadu, for sharing his wonderful experiences. Thank you very much, sir. And I would like to thank today's speakers, Dr. Jacob sir, HOD, KIMS Health Trivandrum, and Dr. Parthasari sir, Professor and Mahatma Gandhi Medical College, Pudukkottai, Dr. Divya for making wonderful academic session. Also thank other faculties and postgraduate and Akirola and Evanlogic for technical support. Thank you. Thank you very much.
Thank you so much, sir. Thank you.
Thank you, sir.
Thank you, sir. Thank you, sir.
Thank you.